Well, let me preface it by saying I'm not going to give you any answers today. I'm just going to expose you to the moral, ethical, and legal questions we in reproductive medicine face every single day. And I don't know the answer. So arrow, right?
That's right. You sure?
Can you hear me?
It'd be better actually if we record it.
Oh,
So if we just put that on your, I don't want to ruin this good time. Oh. Yeah, that's someplace. Good.
also, I would say that the way I approach biology and medicine is to say that my understanding of the complexity of the simplest known life form, the cell, is so great that to think that this could have somehow been thrown together by some freakishly improbable event, in my mind, is nothing short of a miracle. In reproductive medicine, the first thing I thought we would do is review what it takes for you to get pregnant to begin with. Now, this is natural conception, which I don't deal with very much, to tell you the truth. But sperm, when ejaculated, is in the upper portion of the vagina, has to transfer through the cervical mucus, and the cervical mucus is only penetrable by the sperm for a few days in each fertile cycle. The sperm, once it enters the inside of the uterus, and it's estimated only 3 to 5% of the sperm actually get to the inside of the uterus, the lining of the uterus secretes a little fluid. There are little contractions going on that we can actually see by ultrasound that push the sperm through the uterine cavity and out into the fallopian tubes. I had one woman that said, "You mean we got to help them the whole way through?" And I said, but they don't swim up there. Sperm are so small that somebody calculated once to travel that distance would take probably about a week, and of course they would probably die within that period of time. Now, men make new sperm continually throughout their lives. Women are born with all the eggs they're ever going to have. In each fertile menstrual cycle, the eggs, which are stored from embryonic life, a grouping of those will begin to develop. And probably each month you have 200 to 800 eggs that are potentially available. One becomes the dominant follicle. The follicle is actually the cyst that the egg develops in. We can watch it as it grows. It gets bigger and bigger and bigger, finally reaches its mature stage, triggered by a hormonal surge from your pituitary gland, explodes. It's like a water balloon exploding out, comes all the fluid and the egg. The egg, of course, is a microscopic single cell. It has to then get captured by the fallopian tube, and that's not a given by any means. When I went to medical school back in the dark ages, they just implied that this mysteriously got vacuumed up by the tube, but it's a very anatomical, physical process that has to occur. The egg then gets fertilized by the sperm, hopefully, in the outer portion of the tube. It gets transmitted through the tube by kind of a peristaltic action, kind of like the way your intestines move. Now remember, sperm get pushed up there. They get there within 5 minutes, some of them. It takes 5 days for the embryo to go all the way back through the tube the other way. Then it has to arrive on the inside of the uterus. Then it has to somehow implant in the wall of the uterus. Now you're pregnant. The miracle of birth to me is that it ever works right, to tell you the truth. It's so complicated. This is what a normal uterus looks like. The bladder would be towards the top, rectum and colon towards the back. The long tubular structures are fallopian tubes. The white structures are ovaries. And we thought it would be a good idea to explain some definitions that we're going to be talking about, because there's a controversy between legal, ethical, and moral terminology, I guess is what I would say. For example, the gamete is the egg or sperm. When fertilization occurs, now a gamete has half the number of chromosomes that a mature adult cell has. So that when they fertilize and join together, now we have a full complement, half from the male, half from the female. This then, by terminology, is called a zygote. Now, people that don't want to get into moral and ethical issues have redefined the zygote. Now they call it a pre-embryo to get around some of the laws that govern abortion and other, well, specifically it was designed for people doing in vitro fertilization, and if something were to happen to the zygote that occurred in the laboratory, you wouldn't be guilty of anything. Once this zygote, like I told you about 5 days after fertilization, implants on the inside of the uterus, it's called an embryo. Now, an embryo is just kind of an amorphous mass. We call it an embryonic plate because when we look at it by ultrasound, if you look at one view, it'll be narrow and skinny, another 90-degree angle, it'll look kind of fat and round. But it doesn't have any recognizable components by ultrasound. This goes through about till 8 weeks. Now, this whole period we call organogenesis. This is when all the organs are first created. At 8 weeks, arbitrarily, it's assigned the title of a fetus. Fetus then is just growth and maturation from that point all the way until delivery. There's another terminology that's used in legal language, which is called independent viability. That means that the pregnancy has progressed to a point where it could exist outside of the uterus and survive. Maybe. There we go. These are gametes. These are sperm right there. And I think I got a picture of eggs. There they are. Oops. These are well, I passed it, but anyway, those were unfertilized eggs. There they are. They are controlled or covered by a grouping of cells. We used to call them nurse cells, but their fancy term is granulosa cells. And for those of us that are older and had to take Latin back in high school, this is called a corona radiata, a radiating crown of cells. Now, the sperm obviously can't get to the egg when it's surrounded by that, so all of the sperm contain little, look like little beanie caps we call acrosomes that secrete chemical that helps to disperse this corona radiata, exposing the shell of the egg. And just like a chicken egg, it really has a shell around it. It takes thousands, if not hundreds of thousands of sperm to allow for the biochemical changes that are necessary for one sperm to penetrate through that shell. Then biochemical changes have to occur again to prevent other sperm from penetrating, so that there's only one sperm that's actually used for fertilization. Okay, this is in the upper left, that's a fertilized egg, but we can't really tell except by that little cell over to the side, which is called a polar body, which gets extruded at that time. The first time by a microscope that we can tell that the egg was actually fertilized is about 18 hours later when we see the development of those two little spots on the inside. These are called pronuclei. One of them represents the genetic material from the male, one of them from the female. They then disperse again out into the fluid, and cell division by mitosis begins. We have four cell stage, 6, 8, 10, so and so, until we get to what we call a morula stage, which is at about 4 days. And a morula, again, is Latin for mulberry. Basically, it's got so many cells that you can't really identify individual cells. The days that we use, other clinics use different, but we used a day 5 to transfer the embryos back because this is about the time they would naturally reach the interior of the uterine cavity. And this is called a blastocyst. Now, there's a separation now where there's a central cavity full of fluid that's going to be ultimately the amniotic fluid, an outer ring of cells that's going to be the placenta and other membranes, and then a cluster of cells on the about 4 o'clock position there. That's called the inner cell mass. That's the actual baby itself. And remember, all of them have the same genetic structures, and once fertilization occurs, the entire blueprint for everything that's going to happen throughout your life is already established. So, in contrast with others in our field, I believe that with the moment of conception, this is a human life, and it's complete. It's just not mature yet. And I'm like, I'm finally getting there, I think. On ultrasound, this is what we see. The very first thing we can see in the upper left is just a sac within the cavity of the uterus. You can't see any structures. Remember that what we call 5 weeks is actually 3 weeks of conception, because we measure everything in the old-fashioned way from the last menstrual period. At 6 weeks is the first time we can actually see the embryo, and it's 2 or 3 millimeters long. Now, to give you an idea, if you're not into the metric system, there's 25 millimeters in an inch. So this is tiny, tiny little thing, but believe it or not, at that little bitty stage, we can see a heartbeat in it already. Wow. Now, the heart actually physically started beating 17 days after conception, but of course it was too small to be able to see by ultrasounds and things like that. At 7 weeks, it grown. It grew from 2 millimeters to 8 to 10 millimeters in 1 week. There's not a cancer that grows that fast. This is a phenomenal growth rate. 8 weeks, now it's starting to get some shape to it. Remember, this is our point of conversion from an embryo to a fetus, meaning that organs have formed. There's just growth and maturation from that point. And it just gets bigger and bigger and bigger. We can see, starting at about 8 weeks, fetal movement. In other words, it can move arms and legs, and you can discern where the head is. The heartbeat gets faster and faster. As a matter of fact, by 8 weeks, usually the heart rate of the developing conceptus is what we call it, the conceived embryo, 140 to 190 beats a minute. As an adult, your heartbeat probably is closer to 70 or 80. And in the case of abortion, and we're not, like I said, I'm not going to go into things like whether it's right or wrong. We're just going to present, first of all, the legal definition. And legally, in the United States, a woman can choose to terminate a pregnancy up until 20 to 24 weeks of pregnancy. That's halfway through the whole pregnancy. We separate abortions. By the way, spontaneous pregnancy loss, which we call a miscarriage in medical terminology, is an abortion. Abortion is just a loss of the intrauterine placement of the pregnancy. They can be elective, which means by choice, or they can be medically indicated. That is, there's some threat like genetic disease or malformations or things to the baby or a threat to the mother. Another legal question comes in about personhood. And personhood is an arbitrary decision because by our Constitution, a person has rights. So when do we assign personhood to it? And this is a big controversial issue right now. For example, a woman can choose to terminate this pregnancy, which she considers to be her body, her choice. Well, it's not all her body either. It's a body inside her body. On the other hand, if she were to do something threatening, or if a man was to commit some violence towards her, it's murder all of a sudden.
Yeah.
So this is the controversy about, is this a living being with all the rights that all of us are granted, or is it just some non-entity? And I don't know the answer to that. Nobody seems to. The laws are very controversial about it. In my mind, again, even with that first point of fertilization, before there's even been a single cell division, it is a potential life. Now, what we'll do is, at the very conclusion, Harry, you probably ought to change the battery. Now, we're going to deal with where we that are practicing medicine come into these kind of issues. It's easy for me to say, no, I don't do abortions, I don't believe in abortions, but we're going to look at some standard things that everybody in our field is going to come across, and that is contraception, for example. As you know, the Roman Catholic Church is against any form of contraception, but a very popular form now is called intrauterine contraception. Intrauterine contraception means there's a placement of a plastic device on the interior of the uterus, which is designed to prevent implantation. Remember that the concepti has been fertilized and developed all the way to at least the blastocyst stage before it ever arrives on the inside of the uterus. Now, when you read the manufacturer's comments, they're going to try and make all kinds of excuses. Oh, it can impede sperm penetration, it can do this, it can do that. But no, it's preventing implantation. Interestingly, this is probably one of the oldest methods of contraception. In fact, it was present in biblical days. They used to, in camels that were going on caravans, they used to insert rocks in the camels to keep them getting pregnant while they were on this caravan. Now, who thought to do that the first time? I'll never know, but that's where the thesis behind intrauterine contraception came about. Same thing with morning after pill, which, by the way, women can obtain without a prescription over the counter. Now, this is for people who may have had unprotected sexes and plan to prevent pregnancy. Again, the manufacturers give you all kinds of excuses as to how it does this, but it's really preventing implantation again. So it's not stopping fertilization or any of those things. Medications that abortion clinics use, like misoprostol and mifepristone, RU486, cancer, chemotherapies, radiation, all of these things will cause a loss of a pregnancy that's already established. Here's a question that I used to face a lot. We've gotten a lot better at avoiding these, what we call higher order multiple pregnancies. These are things in excess of twins, kind of like octomom or something like that. And we face these legal and moral questions every day. One of the questions would be if the physician was going to make a decision, or whose decision is it as to which one would be damaged or destroyed. And sometimes the mother might make that decision. Sometimes it's based on genetics, if they happen to test each one of them. Sometimes it's based on convenience. Is there a risk to the remaining babies? Because we know that if you had a quadruplet pregnancy, there is a grave risk to both the mother and the babies for some serious complications. So our best bet is to try and avoid that to begin with. And who has that final right of decision? Believe it or not, the doctor does, usually. This is an ultrasound picture of a triplet pregnancy. And what we want you to see is that all three of those babies, by visualization, by ultrasound, look identical. You can't tell the difference if one's better than another. These are just those early stages of development. Upper left is 6 weeks, upper right 7 weeks, bottom is 8 weeks, or early 8 weeks. Because in reality, it actually looks like a small child. These are some of my personal experiences, patients of mine, and I was just thinking when we brought up that topic of selective pregnancy reduction, and you see the outcome of patients who elected not to do that, could you make a decision about which of these kids you would destroy? I wouldn't be able to. And this poor lady over here had 5 babies at one time. Again, this was a while back. And since this is in a church setting, we'll tell you, I was laying out for all the risk and everything because ultimately it has to be their decision. And legally, we have to let them know what the options are. And she said no, she was going to go forward with this and everything. And her church supported her throughout this whole pregnancy. She told me that she came by one day. I mean, she had a little minivan and all these cars. It looked like a bus. They were about, 9 months old, a year old. She puts them down on the floor in my office. They just spread out like ants. There was I don't know how they did it. But she said in the first year, they never even cooked a meal. And she and her husband had to fight to get to change diapers because it was all the church members taking care of them throughout this. And fortunately, everybody was healthy. No complications. I want to tell you again where we meet another legal moral conflict that wasn't present in the day that I trained, but now training in the procedural technique of doing abortions is mandatory to get certification in as an OBGYN, for example. So, this brings up that ethical question about what about conscientious objection? What about if you say, I'm morally against abortions? Well, they can withhold your certification. However, it's my understanding from talking to some of the people at the university, they can allow these people and women that are already miscarrying or that have stillbirths or things like that to allow them to perform them in those circumstances. As I mentioned earlier, we are legally required, no matter what our own personal ethical feelings are, if a woman is pregnant and requests termination of that pregnancy, we are obligated legally, and we can go to jail for this, to refer them to an appropriate source where they can have that done if they want to. These were just some of the, both the American Society of Reproductive Medicine, American College of Obstetrics and Gynecology, both of them have this legal requirement. And both of them are trying to deal with the ethical issues, but they don't deal with them in a moral standpoint. They deal with them purely in kind of a legal standpoint. And unfortunately, like so many colleges and like so many people are being brought up these days, they don't see things as absolute right or wrong. They have no moral judgment at all. It's purely ethical. This didn't come out very good, but I was just going to show you one of the reasons we have to do that. The capturing of the egg and things like that, like I told you, is not a given. This is a procedure we used to do, and all the way up until about 2000, this had a higher success rate than in vitro fertilization has, which now currently has the highest of anything we do. But this is where we would collect an egg. In the bottom left, that's a needle going into the ovary inside that follicle, that cyst that contains the egg, extract the fluid, identify the egg. We would then load the egg and the sperm into a little tube and catheterize the end of the fallopian tube. So literally all we did was make sure that egg and sperm together got inside the fallopian tube. Catholic Church actually didn't frown on this technique because fertilization did not occur outside the body. So this was our way around it. Then our own inner conflict, I think, would be, like I told you earlier, it takes thousands, if not hundreds of thousands of sperm to allow for natural fertilization. That's what the top picture is showing. They have to break away that cellular debris of the corona radii around it to attach to the surface. Well, that's all well and good. 50%, well not 50, 40% of men are not going to have enough sperm to be able to do that with. And if that's the case, sometimes instead of making sperm by the millions, and a normal sperm count is about 100 million per milliliter. A milliliter, well, there's 5 cc's, 5 milliliters in a teaspoon. That'll give you an example of how many sperm are normally produced. But what if the guy makes 2 sperm instead of 200 million sperm? Well, it's impossible for him to fertilize an egg in a natural circumstance. So we have the ability to take a single sperm. Now you got to remember, now it becomes us making the judgment about what's a normal sperm, and we can only base this on its external physical characteristics. And we're not very good at that, in my opinion, because we don't know what's going on the inside of the sperm. But we can take a single sperm and inject it into an egg by micromanipulation. That's what that bottom picture is showing. And then fertilization hopefully will occur. So my own moral controversies are, did I do the right thing or not? We are now manipulating things that would not have occurred naturally. On the other hand, we know there's a sovereign God who, when I do everything perfectly and there's no room for error, sometimes we fail. Sometimes it seems like I screw up everything all the way around the line. The patient's not working right. The embryologist gives us bad news, and they still get pregnant despite that. So I don't know. I can tell you, Dr. Morgan is a perfect person to present these things to if I want to know, is there a biblical reference to this particular kind of technique, and is it right or wrong? We are faced now with, through something we call cryopreservation, we can take fertilized eggs, embryos, and can freeze those indefinitely. Now, it almost sounds like science fiction, but once a cell is frozen, and they're frozen in liquid nitrogen at like 270 degrees below zero or something, they are unchanged regardless of the period of time. They don't deteriorate over time. I mean, I can't believe that you have a living structure that in this cryopreserved state has no metabolic requirements. You don't have to feed it, water it, you don't have to do anything to it. You can thaw it out 50 years later and it's still in the same condition it was in when you froze it. A lot of doctors, even in our community, will fertilize multiple eggs, get embryos, pick out what they consider to be the best embryos, use those for an in vitro fertilization, and basically just discard the other ones. Or if they freeze them, what do? Let's say the patient gets twins, she's 40 years old, she doesn't want any more children after this. So these are what we call abandoned embryos, and what do you do with those? Can you use them for research? Can you sell them? And unfortunately, I hate to admit it, but some have chosen to do that. They've actually had international marketing of human embryos. It's scary where the future is likely to lead us there. We have something called preconceptual gender selection. This means that you could take sperm, and we have the ability to, it's very expensive, but we can separate X chromosome-bearing sperm, which would have led to a daughter, or Y-bearing chromosomes, which would have led to a son. We can do that in what we call pre-implantation genetic testing. This is once it's already fertilized, we can identify which one's a male and which one's a female. Now, the purposes for doing that originally were to try to prevent certain genetic diseases. For example, hemophilia is only transmitted to males. So if we had a woman that was a carrier of the genetic trait of hemophilia, and we didn't want to give her a son that contained that, we could elect only to put back female embryos. But that means somebody has to destroy the other embryos. Now, just because they have hemophilia, which has always been with us, does that mean they don't have the same rights as some other embryo that's not so affected? And I don't know the answer to that. One of what I see as the biggest problems, and we don't do this at our center, but let's say you've got a 3-day-old embryo. You can extract up to 50%, because these are still in that kind of stem cell stage. You can remove up to 50% of the cells in that embryo without damaging the embryo. And let's say you run a genetic test on, you find that this is genetically abnormal embryo, something that is either going to cause mental retardation or some severe physical handicaps or something along that line. You could elect not to transfer those embryos. Well, that would probably not be such a bad thing, but now we know about a problem called mosaicism, which means that some cells are abnormal and some aren't. So it depended on which one you checked and tested in the laboratory. And we also know about something called autocorrection. God in his mysterious ways, we can test this baby and say, this is abnormal, there's no hope for this, and the parents elect to return those anyway, and they end up with a normal baby. There's not a clear-cut answer of whether we should be doing this. We certainly can do it, but should we? This opens the realm, and I really fear for coming generations as to what could happen, because they're into gene splicing, something called eugenics, where they're trying, almost like Hitler again, trying to create a perfect race. But they're bypassing the normal variability and flexibility that has created the human races that exist. Before I started to bring a picture of my children, I got 7 kids, and the thing I wanted to show you more than anything else is that none of them look alike, none of them look like each other, they're just as different as can be, and everything is probably determined by genetics, their personality, their risk for diseases. So it's not just eye color, hair color, and things like that. We can do what we call prenatal genetic testing, and this is what most women, especially as they're older, are exposed to, because most serious genetic risks occur with aging. And this is our ability to extract either fluid from around the baby, culture it, and grow embryos, or now we have something we call cell-free DNA testing, and I'll show you one we just did recently. In fact, this was just last month, and I don't take care of pregnant women, but she had been sent out to an obstetrician. The obstetrician, for some reason, said he couldn't see her for about a month, and we were getting kind of late in her pregnancy, so we went ahead and ordered the test for her, and sure enough, trisomy 21 is Down syndrome, for those of you who don't know. Down syndrome is everybody knows what we call Mongolism and things like that, and it can go from minimal retardation in physical deformities through massive, severe with cardiac defects and a lot of other problems like that. My job is just to let them know what that is. I think everybody knows that Sarah Palin, for example, elected to keep a baby with Down syndrome that she knew about ahead of time. These weren't available in the past. We can do these as early as 10 weeks when it was involving amniocentesis and what we call quad screening and stuff like that. You wouldn't get the results until about 18 weeks. So at least we have the ability to do this much earlier. And my job is just to let the patients know the results and let them know the consequences, let them know what's the risk of this happening again, etc. We already mentioned briefly cryopreservation, and we have the ability now to cryopreserve eggs. I don't know, we've been doing IVF. I got to do the very first IVF in Florida, as a matter of fact. It was way back in 1983. Forgive me, I don't know how long I've been in practice, but it has evolved dramatically from then. We were able to freeze sperm prior to that. We've been able to freeze embryos subsequent to that. But nobody could freeze eggs until about 5 years ago. And I'm so proud to say it, but one of my old students, when I used to teach at the university, was the first person in the United States to actually develop a physical technique for freezing eggs, because this is going to alleviate a lot of the moral issues about what to do with these excess cellular material. Problem becomes then is who really owns these? For example, if a young woman freezes eggs and subsequently, let's say she dies, then whose property are they? You know, one would think, and if she doesn't include it in her will, I don't know what the answer would be to that. You know, we've had a policy in place that Dr. Morgan helped us develop many years ago, that we will not fertilize an egg unless they have signed a consent form guaranteeing us that they'll either use those themselves or we'll put these embryos up for adoption. And there actually is an embryo adoption center. I think it's in Knoxville. It was established by the Christian Medical and Dental Society. And it's just like any other adoption. You have to go through home studies and all these things. Except they're not quite so guaranteed of success because you have to put the embryos in somebody to carry them. We have to deal every day with homosexual relationships where they come in asking you to help them create a child. In the case of women, it may be something as simple as donor artificial insemination of the recipient. In the case of males, they're obviously going to require eggs from some sort and what we call a gestational carrier, a surrogate carrier. You know, is this legal? Yes, it's legal. In this country, it's not in Canada, by the way, but in this country it's legal. Is it moral and ethical? That's an individual's decision based on their interpretation of biblical principles. What about single parenthood? Single parenthood might be, in fact, there's a whole organization called Single Mothers by Choice. You know, if she decides, she comes in, she's 35 years old, there's no man in her life, she doesn't see any future potential, but a lifelong desire of hers has been to have and raise a child. Should we help her in that conception with inseminations, basically? What about people with child rearing disabilities? For example, if they have physical disabilities that would prohibit their, let's say it's a quadriplegic, they can't really care for a baby themselves, but we have the right to make that judgment on whether or not they can conceive and have a child. What about people with mental disorders or other kind of handicap, blindness, deafness, and if so, then, you know, who draws the boundaries on that? You know, it might be, well, I have a little tick, so, you know, should I not have the right to raise children? We, again, have to deal with these regularly. We have men that post spinal injury may not be able to naturally ejaculate because that's a autonomic nervous system factor. We have, again, ways to collect sperm. Now, you go back to naturally, it never would have happened. What about posthumous reproduction? This really has to do with people that have died. There's two ways to go about this. We can have collect sperm from a recently deceased male. We can collect eggs from a recently deceased female that are still fertilizable. There was a great big case back in the late 80s of this really wealthy person in Australia who he and his wife had gone through in vitro fertilization and wasn't successful, but they had frozen embryos. They died in a plane crash. Well, he had a vast fortune that he had saved up through his life. Well, the embryo, if this were to be transplanted to somebody else and yield a conception and baby, would be the heir to this vast fortune. And so as you can imagine, there was a lot of families squabbling about who got to have these embryos and everything, and it would have been a catastrophe. The Australian government, however, prohibited transfer to anybody just for that reason, because it's kind of like an insurance policy in a way. Then we deal again every day with women that have decided to put off their child rearing on the basis of career or other decisions, or they weren't married earlier, and come in later than is traditional. We know in a woman there's a declining potential for pregnancy, live birth. There's an increasing risk of miscarriage, increasing risk of genetic abnormalities, all of which are age-related. So we come across that question, how old is too old? And can I work this? Perfect. This is a little cartoon I ran across, and one lady said, you're looking a little tired. The decrepit lady sitting right next to her says, oh, that first trimester is always difficult. This is one of our patients, as a matter of fact, who not only conceived at 55, and by the way, these are donor eggs, because obviously she's postmenopausal. Harry would be interested. She's a forensic psychologist, as a matter of fact. Really well educated. Her husband was too, and they were in perfect health and everything. It's one of those kind of things that we facilitated this, but you know, I don't know in my heart whether this was the right thing to do or not. I know I adopted a child when I was 50 years old, so I wasn't concerned with their ability to raise a child. It's, are they going to be there for them? And I guess nobody can predict that. But like I said, a lot of times I see it, it's not my position to play God and make those decisions. What about people with certain diseases that we know would or could affect the baby? One of the things we test for now routinely, and this is not legally mandatory, but Fragile X, which is a genetic disorder, which is the leading cause of mental retardation in our country. Everybody knows probably about cystic fibrosis. That is a required thing, but it's coming into view, and psychologists and psychiatrists are well aware of this. There seems to be strong evidence to suggest that psychiatric diseases like schizophrenia and probably things like bipolar disorder, major depressive disorder, they seem to be genetic or familial. And it's not really clarified yet, but should you take a schizophrenic patient and help them to have a baby? Now, if they do it on their own, don't have to accept any moral, ethical responsibility for that, but when they come in and ask you to help them, that's a little bit different. My wife, for example, carries this BRCA mutation. BRCA, and women probably know what this is, but it's a genetic marker for breast cancer risk. And if you carry one of these mutations, it increases, or you are at increased risk. The normal risk of breast cancer is about 10% throughout your lifetime. If you have a BRCA mutation, it's 90%, and it happens to young women. Her sister, for example, died before she was 50 and had 2 separate episodes of breast cancer. It's also a marker for ovarian cancer. And just so you won't be misled, it came down on her father's side. The father had 2 sisters that had it, and they also tested positive. So we knew it was there, and it gives you an opportunity to do something about it. But because it happens in young women, they have an opportunity to remove the breast tissue, take out their ovaries before they ever even conceive. And we have the right to put that resultant child at risk for those things. We know that HIV is transmissible across the placenta. And that's becoming a big issue now, as to whether we should affect carriers of HIV. Pregnancy in discordant couples. Discordant just means where one partner is affected and the other one isn't. Because sometimes like in the case of HIV, for example, let's say that the male is HIV positive. Well, we can take his sperm and we can do all these preps to it and everything like that, but can we guarantee the female, if we inseminate her, or even if we just fertilize an egg outside their body, can we guarantee her we're not transmitting that virus and putting her at risk? And the answer is no, we condone that. But is it legal to do it? Yes, it is. The multiple pregnancy risks have been a significant problem in the past, and that's what we were talking about, something called selective pregnancy reduction before. Now in the forefront, these are the really scary things. Cloning. Can we clone something? Well, they've already started, believe it or not. And certainly we can clone other animals, but we can do it in human beings. We can take a 50-year-old woman's egg, or any cell for that matter, any cell of her body, extract the nucleus, put it in the cytoplasm of another egg that's been prepared for it, and since it's from another cell, it has the full chromosome complement, and you're going to produce what would be the equivalent of an identical twin in the woman herself. We also deal with issues within families. Is it right that if this male is sterile but his brother, I guess this would be kind of biblical, if his brother is sterile, can we take that sperm and transmit it? And what about the moral, ethical issues of the fact that this is not an anonymous donation? He knows he's the father of that pregnancy. What legal rights does he have as the biological father? I know I've given you a lot of questions with no answers, and that was my And that's what this all leads up to right here. When we use, it's what we call third-party reproduction. We use eggs or sperm or a uterus from outside of that relationship. And there are lots of good ethical reasons to do these, I believe. For example, I have a woman right now. She was pregnant with her husband. Previously, she developed something called dissection of the aorta, almost died as a result of that. Well, they've forbidden her to get pregnant again because it would be such a great risk to her. Well, the husband and wife don't have any trouble getting pregnant, but it wouldn't be safe for her to carry the pregnancy, so we can get a surrogate mother to carry the pregnancy, and you just synchronize their cycles. It's really not as difficult as it sounds. And then, but what would happen if she chose her mother to be the surrogate? Now, again, we're dealing with all kinds of critical questions, or a friend, or whatever, because there are other questions once a child is born. Who is the parents and what are their legal and ethical rights? Because we have both biological parents and recipient parents. And in some cases, what we call transient parents, that would be like a surrogate. Oh, this is another cartoon I found on that, if I can get it. No. There it is. And it talks about choices of birthday cards or things like that. I thought it was really funny they threw in an attorney there, because we have, it requires a very complex contract for when we're dealing with surrogating and stuff like that, because, for example, the surrogate mother is pregnant. Well, what if so we call her the birth mother, what if the biological mother, the source of the egg, decides that she wants her to have amniocentesis or some invasive test to check for genetic disease? What if she refuses? You have to cover all that stuff in a contract ahead of time. What about breach of contract? What about when she has that baby, doesn't belong to her, doesn't have any of her genetics in it at all? What rights does she have? And you've probably all been aware that there have been cases in the past where they elect not to give up the baby again, even though it's somebody else's, genetically. Whoops. Went too far. Thank you. No, other way there. That was way too far there. I have to get it back up. But really what we were going to talk about, and I really wanted you to see this last slide if I could. Can you back it up? Okay. Well, we're not going to get into stem cell research because that's way too complicated, except to say that we can get stem cells from any potential source. It no longer has to be embryonic stem cells. The difference is, just so you'll know, when you read about the vapor and stuff like that, we have what we call pluripotent stem cells. Those are embryonic, which means they can become any tissue anywhere in the body, and others that are committed or they're pre-programmed to become a specific kind of tissue. I want to bring up just briefly conscientious refusal. That is, for example, who has the right to refuse to do something else? Because we're caught in a legal battle of abandonment issues if we tell a patient we're not going to do something and we don't find them an appropriate source. Or patients, for example, Jehovah's Witnesses, where they can tell you that despite your better knowledge, they will not receive any blood components or transfusion. And we have to make a decision if do we want to take care of them. Well, sometimes this is an emergent type of position where you don't have that choice. But our ultimate goal in reproductive medicine, this is the one I wanted to show you if I can. Can you forward it, please? There you go. There it is. That is my granddaughter when she was a little bit younger, just to show you that ultimately what we try to do in my field is to try and provide the best outcome for patients that are in difficult circumstances of something that should be natural and normal, but for whatever reason is not. I don't think we have any time, but if there are any pressing questions, I'll try to address them. Yes, ma'am.
You said that abortion is legal 20 to 24 weeks. But what about like partial birth abortion? I mean, that's way out.
Oh yeah, that can go up to 20, well, it can actually go to 32 weeks. And 32 weeks is a survivable baby, easily.
Is that legal then? I mean, you said it was 20 to 24.
It is legal, yeah, but it's not what we consider traditional. This is, these have to be unique circumstances, because typically most hospitals won't allow them and things like that because of the ethical issues. Because you're really killing a baby that is, that could survive on its own. That was the deal we were talking about, independent survivability. And obviously, most rational people wouldn't consider that an option. Oh, yes, sir.
I just wondered what you would advise or whatever a young person going into medical college when it appears that Prometheus was given a chair that's not honorary as a professorship.
Menopause?
No. I was saying, what would you advise a young person that's prospective going into a medical college when it appears that one of the chairs, professorships, was given to Prometheus, and it's not an honorary position?
Well, I think when you go through medical school, and I can only speak on behalf of myself and the fact that I taught them for 7 years, you're going to change your whole perspective on life. You know, most people haven't ever done an autopsy, and you know, that's really what began to make a major change in my perspective of God and creationism. When you see a body with the organs removed, and you look inside the chest cavity and see the ribs in there, it reminded me of looking at a canoe, the interior of the old wood canoes. And the first thing that came to my mind is, that's not a person, that's a carrier state. And then I began to really realize that this body is just a temporary container. I think so. Life, death, creationism, evolution, yeah, they're going to be biased by all of those things in colleges. You know, you would be. Ben Stein did a movie a couple of years ago showing how you're ostracized by the remaining scientific community if you don't conform to their ideas about molecular evolution, which I don't. Yes, sir.
Have you seen any direct correlation between abortion and breast cancer? I saw a study one time, a couple years ago, where they discussed that.
Well, there are associations with everything. You know, it's kind of like smoking. If you smoke, oh, it's been associated with this and that and this and that. That's not the same thing as being causative. And it just means that there is a statistical association, like the big one now, vitamin D deficiencies in women, and breast cancer, and cardiovascular disease, and autoimmune disease. It doesn't cause it. It's just a statistical increase, it seems. So I don't think so.
Well, isn't it true that the breast has cells which, when become pregnant, they kick in to breastfeed, and when you abort the child, rather than the body aborting the child, those cells do not know what to do because you force abort? You understand
Well,
my
for
question?
example, birth control pills are a
Yeah.
pseudo-pregnancy,
Mhm.
which means as far as the hormonal environment goes, they're identical to being pregnant. That's how we can control your cycle. And the average woman in the United States nowadays takes birth control pills for 20 years out of her life. Your entire reproductive life is probably only 40 years. So, and each natural menstrual cycle, you go through all of those changes too. Your body is preparing for pregnancy every month. And if you recall, if you have any children, the first signs of pregnancy you had were, it just feels like my period's trying to start. Something just interrupted that. It was a feedback mechanism. Thank you very much.
Steve, thank you so much.